Hello everyone, I'm Michelle Lair. I completed Concordia's DNP program in December of 2013. I would like to share my quality improvement project with you. I titled it Improving Pneumococcal Vaccination Rates. The clinical problem. According to the World Health Organization, invasive pneumococcal infections are a major public health problem worldwide. The Centers for Disease Control estimates that invasive pneumococcal disease for individuals aged 19 to 64 accounted for more cases of invasive pneumococcal disease than all other ages combined. In 1990, multi-drug resistant strains of pneumococcal pneumonia started to appear, and now they're on the rise. The CDC reports that there are pneumococcal strains that are resistant to frequently used antibiotics. These include penicillin, erythromycin, sulfa, tetracyclines, levofloxacin, and even vancomycin. So what can we do as clinicians? We can vaccinate. My PICO, or clinical question, is in adults aged 19 to 64 at high risk for pneumococcal pneumonia, how does a computerized health maintenance reminder and a team approach compared to the current practice affect pneumococcal vaccination rates within 2000? Accepted evidence-based practice guidelines. The ACIP releases their vaccine recommendations yearly. It is recommended that individuals at high risk for pneumococcal disease be vaccinated. High-risk individuals are identified by the ACIP as young children, adults age 65 and older, and adults age 19 to 64 who are smokers and those that have an illness that put them at high risk. High-risk diagnoses include chronic heart disease, including congestive heart failure and cardiomyopathies, chronic lung disease, including chronic obstructive pulmonary disease, emphysema and asthma, diabetes, cerebrospinal fluid leaks, cochlear implants, alcoholism, cigarette smoking, functional asplenia, anatomic asplenia, congenital or acquired immunodeficiencies, HIV infection, chronic renal failure, nephrotic syndrome, leukemia, lymphoma, Hodgkin's disease, generalized malignancy, solid organ transplant, and multiple myeloma. How are we doing as a nation? The national average for pneumococcal vaccination rates in adults aged 19 to 64 at high risk for pneumococcal pneumonia is 16.6%. I currently work within the ThedaCare health system. ThedaCare is a health system in northeastern Wisconsin. It includes 4 hospitals, 22 clinics that cover 9 counties and approximately 150,000 patients. Patients treated for pneumonia at a ThedaCare hospital had an average length of stay from 3.47 days to 3.89 days. Another measure is cost of hospitalization for pneumonia. For ThedaCare hospitals, this varies from $9,674 to $11,649. How is ThedaCare doing with its immunization rates? The childhood pneumococcal immunization rate is at 88.41%. Pneumococcal immunization rate for persons age 65 and older is at 89%. So how do you think the pneumococcal immunization rate for persons age 19 to 64 is? Well, it peaked at 12% during the height of influenza season in 2012. Appraisal of current evidence. How many potential causes for discrepancy between evidence-based practice and actual practice do you encounter each day? Practice gap that's identified by the literature includes lack of standardization. For example, childhood immunizations must be addressed for school admission. The limited time during an office visit is a barrier. Complex immunization schedules, misconceptions related to immunizations, complex insurance plans, and providers being uncertain whether an immunization is covered. This is likely to be less of a factor in 2014 with the ACA, but it has caused new concerns for healthcare providers, such as how are immunizations going to be reimbursed. Patients report similar barriers to immunizations, and that sometimes immunizations are even only being offered during a preventative care visit. What evidence-based strategies have worked? Immunization information systems can aid in improving immunization rates at the point of patient contact by allowing clinicians to view immunization histories and then to flag those patients that are due for an immunization. Standing orders have helped. Standing orders authorize nurses and other eligible healthcare team members to assess patients' immunization status and administer those vaccinations according to a specified protocol. Clinician incentives have also been found to be helpful. Appraisal of evidence and reviewing current literature. A study by Gannon, Quazim, Snooks, and Snow of 2012 reports a success in adult immunization rates through the redesign of immunization protocols. In another study done by Kim, 2012, they attributed the immunization project's success due to shifting the immunization responsibility and accountability from the clinician alone to a team approach. In this report, Kim states that the clinicians felt pressured by time constraints of the office visit and in reviewing immunization status, which was burdensome. One of the critical system changes was the delegation of vaccination management from the clinician to trained nursing staff. This resulted in significantly improved pneumococcal vaccination rates. Evidence related to the pneumococcal vaccine itself. Research shows a correlation between immunization and reduced death, complications of pneumonia, and length of stay among hospitalized patients with a community-acquired pneumonia. Results noted that individuals with documented prior pneumococcal immunization had higher survival rates. Immunized patients had a decreased risk for respiratory failure, acute respiratory distress syndrome, tracheostomy during hospital stay, acute renal failure, sepsis syndrome, and cardiac arrest during hospitalization. Length of stay for the patient with prior pneumococcal vaccination was an average of 4.5 days, with an average of 6.5 days in patients that were unvaccinated. Cost savings of a 2-day shorter hospital stay are huge. Implementation of the project used evidence-based immunization strategies to improve pneumococcal vaccination rates in adults age 19 to 64 with high risk. Implementation of this project included creation of a computerized health maintenance reminder. This was programmed based not only on age, which previous immunization reminders were, it was also related to specific ICD-9 codes. ThedaCare uses team guidelines and protocols for immunizations. We updated those protocols to include the pneumococcal vaccination status for high-risk populations age 19 to 64. Project data was collected March through August of 2013 and compared to data from March to August 2012. The IT department created a report detailing the total number of eligible patients with a Theta Care provider, and then the number of adults in that group that had the health maintenance reminder satisfied, meaning they had received the immunization. I used a t-test to compare the two groups. The Pearson correlation for March through August of 2013 group was 0.9948. This indicates a strong correlation between the pneumococcal immunization rates and the health maintenance reminder plus a team approach. The Pearson correlation for the control group, the March 2012 through August 2012 group, was 0.7253. This indicates a weak correlation in the control group. Control group is the standard practice of clinicians offering the pneumococcal vaccine, and it did not significantly affect immunization rates. What are the implications for practice? A computerized pneumococcal vaccination health maintenance reminder combined with a team approach equals improved vaccination rates for pneumococcal disease. Completing this project, as well as completing the DNP program, has improved my ability to find and utilize research and evidence-based practice guidelines. It has enhanced my self-confidence. Moving forward, I would like to put the desire to lead into action. Thank you for allowing me the opportunity to share my quality improvement project with you. I encourage everyone to ask questions. This presentation only scratches the surface of the project. There are many pre- and post-implementation factors that were not included in the presentation, and I would enjoy very much to share these with you throughout our discussion this week. Again, thank you very much.